Well, Charles asked me to start the discussion, and it really is a conversation, much more than a debate. I was struck in reading this wonderful book by Charles called What Would You Do? And that Charles and I are probably not so far apart on many of the issues. The title of the book refers to a problem that Charles has frequently encountered during his years as an acknowledged ethnographer of medicine, that sometimes people will approach him and ask him, since he's rounded with surgeons for years and worked in neonatal units and has studied medical genetics in detail, they will put him on the spot and actually say to Charles, you know, what would you do in this circumstance or that circumstance? And I think that's where the title comes from. And the difficulties in which he finds himself confronted with a question like that. That was what drew me into the book to begin with. But then as I read through the book, I came upon this section very close to the end of the book, some of which is quoted actually in the program, where Charles, legitimately referring to an earlier paper of mine, says that Mark Siegler has argued that only physicians should be allowed to act as clinical ethicists. Skipping some things here, Siegler worries that new strangers at the bedside will make matters worse because they will display the counterfeit courage of the non-combatant. Clinical bioethicists will advocate a course of action for which they need not be accountable. A bad situation will be made worse. I'm continuing sort of, I'm quoting and paraphrasing a little bit. Siegler's position did not win the day for a number of reasons. Two are worth mentioning here. First, to a large degree, physicians troubled by their isolation from the community and by their need to share decision-making more broadly, invited non-combatants into the hospital. Siegler was, in essence, trying to cancel the party after the invitations were issued and the responses returned. Second, a major part of the critique of medical practice by bioethicists and others concerned the dominant role of physicians and the way the role was used to usurp personal autonomy of patients. Here it is perhaps necessary to add that in modern warfare, Siegler's arguments came after the time when a social consensus had been reached that medical ethics, just like war for generals, was too important to be left to physicians. And then the quote that's in the brochure, where it says, clinical bioethicists will advocate a course of action for which they need not be accountable. Siegler lost the debate, such as it was, and has since admitted that perhaps he was wrong. I think I got the gist of it. Now, while in the spirit of civil discourse, I'm prepared to say I might not have won the debate. Maybe indeed I lost the debate. I'm not sure that I was wrong. And it's or that the war has ended. And so, in a way, I'd like to engage Charles. I'd like to engage Charles in a conversation around those points. First of all, I take it that the title of the book, What Would You Do? And Charles' discomfort when confronted with that question goes part of the way towards saying that maybe some of the non-clinicians are not so eager to join the party at the bedside. And you can give us reasons, but based at least in part on my concerns of a lack of clinical expertise, a lack of clinical knowledge, a lack of accountability, and maybe even the patients not having proffered the invitation. Just 3 or 4 reasons why, but Charles may have other reasons why he's uncomfortable. And then second, I challenge you to cite the source of where I admitted that I was wrong.
Well, I think I would like to point out that that's a very carefully hedged statement. Siegler has admitted that perhaps he was wrong, and what honest intellectual wouldn't admit that perhaps you could be wrong?
No, wait. Perhaps I could be wrong. It's not the same as admitting that I was wrong.
But leaving that aside, and in fact,
Perhaps you know.
In some ways, it seems to me the multidisciplinary nature of this center is evidence of the point in debate. And I should say that the title of the chapter from which the quote is taken from is called Professional Expertise in Moral Cowardice, and looking for counterfeit courage in the non-combatant. And that the thing about counterfeit courage is that it's really difficult to tell from the real kind, because if you act courageously, even if you don't feel genuinely courageous, you may have been. The problem for me is that I can't really do my work if I answer the question prematurely, what would I do, when it's asked directly of me, because precisely what I'm trying to get is as many responses to whatever it is that have evoked the question as possible, as many viewpoints, as many ways as it comes up. On the other hand, most ethnographers that I've talked to who are in my position feel a little bit queasy when the question is asked, because you're in a situation where your skill at developing relationships day in, day out with the people that you're working with is a very important source of the richness of the data that you'll get. So when a genuinely troubled person asks, what would you do, not answering it always feels to me like a breach in the relationship. So part of what I'm really interested in, and that I never keep good enough notes on, is when I provide an answer and when I don't. As when I know that I shouldn't, sort of wander off the reservation, when I decide, well, this is a genuinely troubling enough situation that I can't be silent as a stone. It's not fair. I've been living with these people for a year and a half. They've come to know me. How and when I answer then influences what they next will let me see, what questions they will, what situations I'll be allowed to see, what questions will get answered honestly. And over time, I guess I've come to believe that, when I first started doing field work, I went into the field with a kind of general belief that was in the literature everywhere, that observer effect in medical settings would go away over time because the exigencies of the situation would have people forget that you were there, and they would act like they normally do. And over time, I've come to wonder, to what degree do my subjects, having figured out why I'm there, play to me and try to enact the position, the virtuous surgeon, the conscientious physician, because no one wants to act out the moral cretin, right? I mean, so I don't, and it doesn't make sense for me to say, well, I can always pretend to be neutral and not have reactions, and sort of do this sounding board. But they'll forget that I'm here. So every time somebody turns to me and says, what would you do? The conceit that I'm working under, which is that no one's noticed that I'm there, dissolves. And that essentially that's part of the problem. The other part of the problem is, as a graduate student at Pacific University, I began to feel like I was trapped in some kind of weird socio-linguistic experiment. Every time I wrote on a paper that I turned into the sociology department, I should plus a verb, one must or one ought, and then a verb, that ought, must, or should would be crossed out, and there'd be in the margin, according to whom, says who, what you mean ought, where is this coming from, and it, sort of burned that verb form out of my brain in some ways. So when I then sit at the writing table, I realize how deeply framed normatively my descriptions are, that all of, I just come to wonder about what's the difference between transparency and objectivity? What have I brought to the setting? How much do I trust even my own accounts? And the second 2/3 of this particular book are attempts to revisit fieldwork that I've done and rethink reactions that I didn't rethink at the time because the data was too good to question. It fit such a nice story. It looked so polished on the page. It fit so many things that theory told me to expect that there was no reason to question it. And I was a callow youth when I wrote Forgive and Remember. I was not so callow and not so youthful when I wrote All God's Mistakes. But both were written, before life scuffed me up a bit. Looking at those things 30 years later, I thought, who is this person that writes with such authority, such confidence, and where did he go?
Like Gretchen, I've read Forgive and Remember maybe not 100 times, but 75. And it still, for me, remains the best book ever written about medical education. Not just about surgical education and not just about clinical surgical education, but about medical education itself. It's the words, the language of the clinicians, the words and the language of the students resonate truthfully, even as 30 years have passed since the book was done. The words are not very different from what one hears on the wards these days. A couple of changes in technology and a couple of changes in relationships to attendings and residents, but the basic structure is there, and it's quite phenomenal. Your explanation of your hesitance about what would you do, the title, was couched, as you described it at this moment, largely in terms of your professional calling as sociologist, as an ethnographer. And yet I detect in the book, and here I'm asking you to help me, I detect in the book this second line of reserve. That is, one line is clearly the one that Charles has just described. To do ethnography accurately and effectively, one ought to maintain a certain kind of professional distance. And that's the one he talked about. But I do detect a kind of, you sometimes use the word yourself in the book, a kind of humility of not wanting to overstep your capacity, your capability. In fact, you quote Dan Callahan at one or two points, and I think you quote him with some disapprobation, because Dan sort of says, and I'll try to find this quote in a minute, Dan sort of says, you know, I recognize that I'm not such a hotshot expert on some of these really tough technical matters, but I got to show them. I got to make believe I am, because from that I derive my power and credibility. Here it is. This is Callahan. Unfortunately, the role of the professional, I'm quoting him now, I'm not adding any words, particularly the paid role, offers no special encouragement to indulge the gap between private agony and public sentiments. One gets pushed and tacitly approves the pushing to stay away from the dark corners of doubt and uncertainty, of deeply felt inadequacy. One is asked to bring light, lucidity, and logic, and one is only too happy to accommodate the request. They don't want a dolt, a muttering victim of private struggles with darkness and ignorance. They want a pro, end quote. And Charles quotes that, and I think with the sense that that's not the role he wants to play. When they ask him what he'd do, he doesn't want to make believe he's a pro in this arena. He wants the pros to sort of carry the day.
Well,
help me.
Well, to be fair to Dan, I also, a few pages later, quote him as saying, somehow or other, as we become more professional, we'll need to find ways to become less so. The only way out is to keep returning to the discrepancy between how we tend to think about health and illness privately late at night and how we talk about them professionally. And in fact, I'm not trained to be a clinician. I'm not scared of giving advice. I think I'm a fairly thoughtful person, but none of the advice that I would give would be based on any reason that justified my being in this setting. There's no legitimacy that I can attach to advice that I give. Sociologists practice a generalizing craft. We know how things happen on average in a sample among a population. To make a decision about an instant case is to, as I think I say in the book, is to create, is to perform the ecological fallacy in public. And I'm just too well behaved to do that, and what I think is truly interesting is that I'm not sure my position is sensible. And I'm not sure how I've developed it, because there are other models of research around. There's participant action research, there's collaborative research, there's research that where you're clearly advocating for social change. And there's certainly been a lot of what I would call professional moral entrepreneurship around clinical ethics, where folks have claimed that armed with a 2-week course at Georgetown, with whatever background they have, they can dispense, they can act as if they understood what it is like to sit in judgment and bear responsibility. I'm just not, that's not me. There's a chapter that precedes the one that we're talking about by 4 or 5 that makes the argument that if we think about mistakes as I classically think about mistakes, ethicists can never make a mistake because it's very hard to track back exactly what stream of thought, what recommendation led to what action by what other. And then there isn't a dense enough community of practitioners in any place, since ethics is often a volunteer activity, to want to undergo rigorous self-criticism, because already you're exploiting individuals to do tasks that other folks aren't doing. And, you know, in some ways, I think the wonder of this center is that you've kept alive, you know, this isn't a center for bioethics, or at least not in title. It's a center for clinical medical ethics. And, you know, I think my work has a role to play in understanding clinical medical ethics. But what I'm interested in is what makes something an ethical problem, what makes somebody else feel that they're skilled enough to speak to it, what problems get legitimated as ethical problems, what problems, and there are problems aplenty that are, you know, ethically troubling but never identified as ethical problems. And, you know, so there's this kind of larger sociology of ethics that I'm really trying to play to. And part of the question for me is, how did bioethics get the traction that it did in an evidence-based work? And what kinds of evidence would you actually need to show that clinical medical ethics improved things, made them worse, IRBs made things, improved them, made them worse, that autonomy is more respected now than it used to be, that consent is more informed than it used to be. I'm just trying to figure out how people figure these things out. I grew up in a tradition in which the answer to a question was supposed to be a better question and not a good answer. So I'm undisturbed at all. I'm totally undisturbed by the fact that I don't have, well, sometimes I'm disturbed that I don't have glib answers because I think it would be really profitable. But I just don't have pithy sound bites. I don't have good answers. I do terrible television interviews because I keep forgetting I'm not supposed to have 2 hands. You know, I failed media training every time I go through it. I'm just congenitally, you know, and besides, art makes all of us at Penn sign a non-competition clause, so we can't appear on CNN.
I thought he taught you all media skills, no? Just to highlight for the audience that the issues we're talking about are not in the distant past. It was on November 9th, what day is today, the 13th or 14th? 14th, that I received a letter from Anita Tarzian, who is the chair of an American Society for Bioethics and Humanities task force that sent a report, a long report, 50 or 60 pages, on core competencies for healthcare ethics consultation. I mean, that's sort of what the conversation that Charles and I. Yeah. No, people. I see that. I see Dan Brock was on an earlier version of this. This is the 2nd edition, yes. And on the second edition, there are 14 or 15 names. I see that 3 of the 14 are physicians. So you already begin to see a sort of a balance, a shift in the balance of who's writing the report. And when you turn to a section, and I didn't pick it up just arbitrarily, called Core Skills for Ethics Consultations, I'll just read you the first sentence. We believe that ethics consultation requires 4 categories of skills. 1, ethical assessment skills. 2, process skills. 3, interpersonal skills. And 4, the skills needed to run an HCEC service, including evaluative skills. You know, none of those has any relationship to clinical medicine or clinical knowledge or expertise or clinical judgment. I'm just reading from that sentence. They may later on talk about, you know, having people take a 2-week course or something like it in clinic. Healthcare providers will bring with them a detailed grasp of the clinical context, but others will have to get that through in-service and seminars and conferences, the report says. So these are active issues, 3 or 4 days old, and this issue has been going on for a while. I see a few hands, and Dan, why don't you start us off? Talk right into it.
That wasn't what I had my hand up for, which is, it seems to me, Mark, there's a plausible version of your view. It wouldn't be very controversial, and then there's a less plausible one. The plausible one is clearly for clinical ethics consults. Clinicians have knowledge and experience that I, as a philosopher, for example, don't have. So you certainly wouldn't want to send me in by myself to do a consult in a clinically complex case, and I wouldn't go. You certainly anyway. Now, so that's clear, and I think that that's not controversial. The question, though, is given that one needs what a clinician will bring to the consult, does someone who is not a clinician sort of add value or subtract value? And I think if you look at it that way, then I think Charles is right. That is that over time, I don't remember when you said this, but it was probably about 20 years ago.
Yes, a while ago.
Right. So over time, others who aren't clinicians have become involved. I think the most obvious place is the most obvious place is in consults that go to ethics committees, which have clinicians on them, and they used to have people like me on them. They have a fairly wide range of people, and I think there's some reason to think that the diversity of perspectives that you get when you have something beyond simply clinicians is value added to those consults.
Yes.
So I think we ought to agree with you that you don't send the philosopher in by himself to do consults on clinically complicated cases, and we only ought to disagree with you if you want to say that nobody but clinicians should ever take any part in clinical consults.
Well, no, I don't. No, I think Charles and I are, and your comment helps us. I agree that we're not all that far apart.
No, and in fact, I would think you'd want as many voices as possible. It's just who you have at the bedside that it can be troubling, I think.
Sometimes the consults at the bedside, I mean, I've been involved in consults at the bedside. I've never been involved in a consult at the
Right, right.
But I have been involved in their history.
But I see an expert in consultation. Sue.
So Mark, thank you and Charles very much for this dialogue, helping to highlight some of these issues. I just want to share a few insights from my experience at the Joint Center for Bioethics. And for those of you that don't know the model that's practiced there, it's a group of a number of hospitals working in relationship and partnership with the university. So and each of the hospitals have bioethicists hired there, but there's also a number of departments that are also engaged in the relationship and the partnership. So my experience working with the clinical bioethicists that actually span the continuum from physicians, clinicians of all forms, actually nurses, social workers, all the way to a number of practicing clinical bioethicists that have theoretical backgrounds, philosophers, people with religious studies backgrounds, and anthropology, and a bunch of the others. Is my experience has been there's a rich and robust contribution that each one of those perspectives offers, and especially given the opportunity for those people to then get together on a regular basis and meet. But what I will add is my personal experience is that the clinicians in that situation are much more likely to engage all the way down to the patient family level. Whereas the philosophers and and this isn't the case generally, I don't think everywhere, but my experience in that there is that there's more of a hesitancy to cross that clinical line to picking up a chart, walking onto a unit, being able to actually dialogue really freely as part of the team when you have a clinical background, versus a lot of these folks that are still getting very involved at the clinical level, but are more likely to, for example, go to a conference room and have a conversation with a bunch of the clinicians around the particular case. But I don't want to lose sight of the contributions, I think, overall, that I find both the clinicians and the non-clinicians offer to the clinical medical ethics dialogue.
Nice. Thank you. Thank you. John.
It's still a little unclear, but let me suggest, or let me ask you this. If you haven't, doesn't it show a little ingratitude towards some of your teachers? So in your formation as a clinical ethicist, not as a physician, I think of people like Jim Gustafson or Steve Toulmin or Jim Childress. I mean, the people who you went to as a clinician to try to solve some of the problems that were coming up in the clinical arena that you weren't getting guidance for from your clinical mentors. And then to fast forward from sort of those early days to the panel that just preceded you, it was a difficult clinical ethics dilemma and a research ethics dilemma about an innovative surgical procedure. And we had a panel with 2 anthropologists and a philosopher and 2 clinicians engaging in what I thought was a sort of exchange among equals, trying to figure out this difficult problem. Do you see either of those experiences differently, and are you really saying that only the clinicians had something valuable to say?
No, I'm really not saying that. And if my remarks of 30 years ago sound as if I was saying it, I didn't mean to say it. But as you rightfully point out, and indeed as Charles has pointed out earlier, the origins of the center, which you're pointing to, Jim Gustafson, Stephen Toulmin, Jim Childress's influence, Dick McCormick was an influence here on campus in the mid-'60s, were very important to me as I got on the job training in clinical ethics from some of the best minds in the field of ethics in those first 20 years of medical ethics in this country. And the center, as Charles says, is very much dedicated to interdisciplinary, multidisciplinary work. This panel, which had these 2 magnificent anthropologists joining physicians, was again an example of the regard in which I personally and the center collectively hold other perspectives, philosophical perspectives, theological perspectives, sociology and anthropology. I guess I've always hesitated at the notion. I think you're right, and Dan Brock is right. The solo practitioner, the one who's holding himself out as the pro at the bedside, who lacks the expertise and knowledge and experience and clinical judgment to be such a pro. That worried me then and continues to worry me today. It's sort of Charles's humility in the title of the book that reinforced for me how closely our thinking was aligned on this matter. Preston. Turn it right towards you. Yeah.
Cardiologist, basic science researcher too, because really one area of science where he discovered the bigger subject. But he has always maintained that while he runs the most high-powered lab with PhDs out the wazoo, it is the physician fellows who come into his lab who time and time again ask the best questions. Even though they are not skilled in the techniques, don't know the science like the PhDs do, the postdocs, they always anchor their questions in the clinical experience in the patients. And that's what drives their research. So I'm wondering if what you're picking up on, Mark, is this calling that physicians have to go into medicine and then taking that wisdom into the ethical question. Another experience that I've had, I was out of medicine for 10 years and gone back in now where I precept residents, and I'm reminded over and over again that the judgment that comes from having been a doctor, even when I was out, that never leaves you. And there's a sense of clinical wisdom that I think comes with doctoring that people who don't doctor don't know how to integrate into the decision-making process. And so I worry, like you do, that ethics will only be done by non-ethicists. Because I think that this other domain of knowing is really critical to a decision-making process around ethics. And the conversation has to be both and not one or the other.
Well, I guess I think I turned it back. Where I would disagree would be that I don't see why one would leave respiratory therapists, occupational therapists, nurses, social workers, psychologists out of the clinical wisdom picture. And I'm not trying to, I mean, if I scratch hard enough, part of the motivation for bundling these essays in a book was just a kind of accumulated irritation at being identified as an ethicist. You know, I'm not, never have been that. I mean, I'm interested in ethics. I'm interested in recurrent problems of the human condition. I'm interested in how social groups deal with uncertainty, with injustice, with misallocation of rewards, with all the sort of contingencies of being. But you know, part of me doesn't want to be an ethicist because I don't want to have to be purer than Caesar's wife. You know, there's something that just makes me uncomfortable with the title.
I just wanted to separate three things, and I think actually there's a lot of agreement. I think everybody in the room would agree that a diversity of voices around a complex phenomenon like patient care is a good thing. And the discussions that happen, even if they extend to the bedside with a wide variety of people, those are a good thing. And Mark, I think even you would agree with that. And you've shown that in your, and then once we get agreement there, and you know, there's no better example of it than Charles, the work that you did in your various books, which is just an example of that excellent diversity of voices and the new insights that can come. Once we're there, I think there's a strategic fork in the road. Either you go towards then focusing in a self-serving, power-grabbing way on yourself and trying to define your own standards as an ethicist, which I think is what you're objecting to, Mark, and I think you're right about that. And that's the inward-looking, here's the standards of, you know, ethics consultation, and here's the qualifications. That's a way to keep some diversity out, essentially grab power, et cetera. That's one way to go, and that is, I find very irritating, and I think that's what I heard both of you say. The other way to go is to be outward-looking at outcomes and impacts. Be more patient-focused. Ask yourself, what are the outcomes you're trying to achieve? What are the impacts you're trying to achieve? And rather than defining what the standards are without any reference to the outcomes and impacts that matter, let that diversity thrive in the clinical setting and examine who's really adding value to outcomes and impacts like patient satisfaction, like more ethical care, however that gets defined. So in summary, I just wanted to separate three things and would be very grateful for your response. One is the diversity of views around, even around the bedside, which I think we could all agree is a fantastic thing. The second thing is this attempt at professionalization of something completely unlinked to the outcomes and impacts that matter, which I think actually is a very bad thing because it squelches the very diversity that one's interested in. The third thing is something we almost never do, which is actually focus on the people we're trying to serve, the outcomes and impacts that we're achieving for them, and let that diversity thrive and see how we're doing against that. That's the piece we never do. We never look outward at the effectiveness of clinical ethics. We never try and measure the outcomes and impacts that we're having, or if so, in a very rudimentary way. And rather than be inward-looking and try and define what the guild looks like, I would rather be outward-looking and try and examine how we can better serve patients. And so I wanted to separate those three things and see what your reaction might be.
There's a long second chapter in the book that argues that the professionalization of ethics is a misguided endeavor.
For multiple reasons, but partly because there isn't much definition of what the outcomes are, what the skills necessary are, how to tell successful from unsuccessful performance, and then who would be measuring it, and if you got it wrong, once it was in place, how would you remove it and start over? And wouldn't professionalization gives a factor decrease the number of legitimate voices, and in some ways, once you professionalize the role, how could an institution ignore that professionalization in favor of some more open system without incurring legal liabilities? So I can think of, and those are just the reasons, that's just the first paragraph.
Well, just to follow up on just to follow up on the last comment about that the outcome should be geared towards the patient best. It's not clear that people who are in ethics are trying to have their outcomes geared towards the patient first, or even the clinicians. So you might want to comment on that. I mean, what about situations where the ethicist or a person concerned with ethics would say, well, you know, the clinician and the patient are both very satisfied, but the ethicist is very dissatisfied on, say, the choice of surgery or whatever. Or you give an example of the surgery?
Actually, not sure I understood. Is there a question? Rounds of
I guess you could say it's a question, does an ethics consult
think you're bringing up a point that we're all pretty much in agreement about, and that is the lack of a clear endpoint by which to assess the adequacy or the quality of the outcome of the ethics consultation. I remember that years ago, Ellen Fox convened a conference to look at evaluations in clinical ethics and published a series of papers about it. But it's a very hard thing to look at. In fact, it's tough to look at the outcomes of consultations in general. That is, clinical consultations, not just ethics consultations. Even who the subscriber to the consult is. Is it the doctor? Is it the healthcare team? Is it the patient? Is it some combination of those agents together? You're not even sure to whom you're responding when you do a general medicine consult or a palliative care consult or a geriatrics consult or a cards consult or an ethics consult. And then with that ambiguity about who your response is addressed to, there are further complexities about what counts as a good response as opposed to a less good response. These are really tough questions, and we're not going to solve them, I tell you, before the party. Okay, Marty?
Charles, this is a surgical answer for you. The surgeons in the room will be very familiar with this question. The patient says, "Well, what would you do?" And my answer to that has always been, I would elect the surgical solution. But I am a surgeon, and I'm familiar with successful surgical outcomes, and so I am giving you a biased view. And it may not fit you perfectly, but it is the surgical view. And that's a helpful answer, I think, for Ira. The soft paternalism of Ira when he's recommending to his patient that the patient should go into the research protocol or whatever advice the patient is asking based on his authority is perfectly acceptable. Similarly, Charles' recommendations, his judgment, is very valuable. The competence consists of knowledge, skill, and judgment. And your judgment, based on many years of experience and listening and watching skilled and knowledgeable people, is extremely valuable. All you have to do is put the qualification in that I am approaching this from my role, from my particular viewpoint. There isn't a single right answer to the multiple choice questions in life, and you're giving a judgment that I think is extremely valuable.
In fact, in the field, I often do that. In fact, in the field, I often do that. When asked what I do, I do one or two things. One is, I'm a sociologist, and as a sociologist, I have problems with that. The other is, if I were this is what I might do. I was trying to give myself a little bit of roll distance. You know, I'm not but if I were then I might. And it's what I'm trying to deal with all the time is not prematurely coming to a decision and not usurping anyone's ability to think through and talk with others about a decision. Not to be, and this gets harder the older I get. It's pretty easy to be viewed as a kind of person who, I used to say that being a field worker, I needed great skill at playing dumb, and it came pretty naturally. And it's now harder and harder to play dumb about some of the questions I'm fundamentally interested in, because unfortunately I have left a paper record behind.
Far. Turn it on, turn it on.
Particular to the general, and I think about clinical training being the opposite, learning generalities and trying to apply that to particular. Which leads to this question to you, Mark. Would the ideal be that clinical ethical decisions are made by clinicians with the input of a team of advisors that she or he had the humility to honestly listen to, seek out perspective of, collect information from, in the same way that clinicians should collect information from nurses, other parts of the team, medical record, lab data, etc. Is that what you see as the ideal?
That is very close to what I would see as the ideal. It was 20 years ago. It was 20 years ago that I wrote, referring to institutional ethics committees rather than to ethics consultants and the like, that the rise of institutional ethics committees is unfortunately a sign of the times. Their development symbolizes the dreary, depressed, and disorganized state to which American medicine has fallen. Not only have physicians lost political and economic power, they have even lost the chance to reach medical decisions. Good physicians have always incorporated technical judgments, ethical reflections, and patient wishes in reaching difficult decisions. Institutional committees threaten to undermine the traditional doctor-patient relationship and to impose new and untested administrative and regulatory burdens on patients, families, and physicians. I am desperately worried that the rise of these additional experts who have come to the bedside and are serving on ethics committees and as ethics consultants are encouraging a substantial number of physicians who ought to be in the forefront of wrestling with these complex, difficult questions, are encouraging them to relegate the decision-making authority to people who may not have, as I've said before, the clinical knowledge, the expertise, the clinical judgment, the years of training, for that matter, the burden of responsibility that weighs on clinicians every time they take a patient to the operating room or every time they make a difficult clinical decision. And we would pass that on to other so-called ethics experts. I'm really troubled by that, but I think your approach comes close to the one that John advocated earlier and that others have persuaded me that I believe in, which I do believe in, and that is the team concept. I mean, I believe in team practice of medicine and that doctors and nurses and therapists and social workers and chaplains ought to work collectively to further the patient's interest, and that ethics expertise is nothing but good when it's brought to the bedside to assist the clinician who has to make that final decision. So that would be my point of view. I don't know, I'm going to let Charles have the last word. I don't know if that is close to Charles's point of view.
I actually worried when I was writing All God's Mistakes about a different problem, which the book was written before ethics committees had truly flourished, and I was more worried that autonomy would, on the one hand, be used as a shield to say, when patients said, "What would you do, doc?" or "What would you do in my situation?" to say, "I'm not in your situation, you have autonomy, it's your problem, you figure it out." So I was worried on the one hand about informed consent and doctrines of autonomy being used as devices of patient abandonment. And, you know, that motivated a large portion of that book, because one of the things that people would say is, well, I know when I'm having trouble in a session, I get a headache, and I know I'm out of my league, and then I tell somebody else to go in there and to clean it up, and then the people that were assigned the job of going in and cleaning it up would complain, but I don't have the authority, the moral authority. They're not interested in hearing from me. It's impossible to clean up. So I think that, you know, the balance between delegation and the team, between, you know, individuals and committees, between who gets to raise a question and who gets to give an answer, are problems that are very far from being worked out. Now, I also, as long as I have the last word, I'm not on Facebook, but if you should ever see an issue of Grey's Anatomy and you are on Facebook that you think is inaccurate, you could send a little note in for people to buy Forgive and Remember. And if you should ever see an issue of House in which you think an ethical issue was handled wrongly, I wouldn't mind if you put a little note in and said, there's this book, what would you do, so that I could move up in my Amazon rankings. I wouldn't do it myself, but, you know, I wouldn't mind if others did it for me.
Let's party. Go over to the decaf.